Hi all, and welcome back to Part C of our video lecture for Module 5. In Lectures A and B, we explored anxiety and obsessive-compulsive disorders. Now in our third lecture, Part C, we will look at how we understand these disorders through our different perspectives and the treatment options available. As we explore our understanding of anxiety disorder and OCD, we'll take a look from the psychodynamic perspective, which views disorders as an effect of the unconscious mind, the cognitive behavioral perspective, which is informed by how we have learned to think and behave, and finally the biological perspective, which investigates the structure and functioning of the brain as it influences behavior. From a psychodynamic perspective, anxiety is a danger signal that threatens impulses are nearing the level of awareness. Unconscious impulses and conflicts are believed to lie at the root of anxiety disorders, and we employ defense mechanisms such as projection and displacement to protect ourselves from these thoughts or impulses that are deemed by our unconscious mind as unwanted and dangerous to our conscious processes. Using the example of generalized anxiety disorder, one might hypothesize that unconscious conflicts remain hidden, but anxiety leaks through to the level of awareness. We may not consciously know what is causing the anxiety, but at the level of our unconscious, it is connected to a conflict that remains hidden. Obsessions are believed by psychodynamic theorists to represent the leakage of the unconscious impulses into consciousness, and compulsions are acts that help keep these impulses repressed in the unconscious. From the cognitive behavioral perspective, anxiety disorders are acquired through the process of conditioning. The fear component is acquired through classical conditioning, where previously neutral objects and situations gain the capacity to create fear by being paired with dangerous or aversive stimuli. Remember the experiment with John Watson that we looked at in the first lecture. It was the case of little Albert, the infant who had become afraid of little white fuzzy things because he was frightened by a loud noise whenever they were around. The avoidant component is believed to be acquired through operant conditioning. Relief from anxiety negatively reinforces avoiding fear-inducing stimuli. In other words, if we suffer from claustrophobia, the fear of closed or small spaces, then we will avoid being in these small spaces. When we avoid these spaces, we do not suffer with anxiety. Therefore, the behavior of avoiding small closed spaces is negatively reinforced because our anxiety is removed as long as we stay away from them. This is also the case in our thoughts, we believe that by removing the fearful stimuli, we gain relief from the stress response. Therefore, we engage in behavior that we believe will accomplish this result, namely, engaging in the compulsive behavior we have associated with the obsessive thought. The end result is increasing the compulsive behavior in order to avoid the anxiety created by the obsessive thought. It is also noted that there is a role of observational learning in the acquisition of phobias. Observing the fearful response of others and receiving negative and threatening information can lead to the development of a phobia without any interaction. For example, if you watch as a child your parents scream and carry on when they see a spider in the house, and you hear about how afraid they are and how terrible spiders are, it is entirely possible that you too will develop a phobia for spiders without actually ever interacting with the spider. At the heart of this cognitive behavioral perspective is the belief that dysfunctional patterns of thinking are the underlying reason for anxiety disorders. For example, in the case of a cognitive distortion, such as a self-defeating or irrational belief, individuals with OCD have a tendency to exaggerate the risk of unfortunate events, and therefore engage in ritual behavior to prevent terrible things from happening. These individuals demonstrate an oversensitivity to threat, perceiving danger in situations that most people consider to be safe. they also demonstrate an anxiety sensitivity. That is to say, they have a fear of fear. They are invested in the fear that internal emotions or bodily sensations, such as an increased heart rate, for example, will get out of control, leading to harmful consequences. Additionally, there is evidence of the misattributions of panic sensations, catastrophic misinterpretations of bodily sensations, such as heart palpitations, dizziness, or lightheadedness. The illustration on this slide is from page 129 of your textbook and is a graphic representation of the cognitive model of panic disorder. This model involves the interaction of cognitive and physiological factors. In individuals that are prone to panic attacks, perceptions of threat, real or not, lead to feelings of anxiety. In turn, the feelings of anxiety lead to a bodily response, such as an increased heart rate, as an example. These bodily changes lead to a catastrophic interpretation, which represents the error in thinking. This misinterpretation intensifies the perception of a threat, which further heightens anxiety, and so on in a vicious cycle that may culminate in a full-blown panic attack. From a biological perspective, one avenue of research is looking at a genetic factor in creating predispositions to anxiety disorders. Twin studies have demonstrated higher rates of anxiety between monozygotic or identical twins rather than dizygotic or non-identical twins. There are many different genes involved in the etiology of anxiety disorder. Each gene makes a small additive contribution to a person's risk of developing an anxiety disorder. Research suggests that genes exert their influence by interacting with particular environmental events that increase the likelihood that the individual will experience an anxiety disorder. Research indicates that symptoms of social anxiety are influenced to some extent by genes. The biological perspective also examines the functioning of the brain, including the role played by neurotransmitters. Research has implicated GABA neurotransmitters in the etiology of anxiety. GABA is an inhibitory neurotransmitter whose role it is to help to tone down excess activity in the nervous system. When GABA is inadequate, neurons can become overstimulated. The illustration on this slide comes from page 127 of your textbook and is a depiction of the fear network in the brain. There is some evidence that panic attacks have biological underpinnings. This influence is mediated by the fear network in the brain, which is centered in the area of the amygdala and involves its interactions with the hippocampus and medial prefrontal cortex. It is proposed that cognitive factors or errors in thinking may be involved in explaining these biological sensitivities. Studies have shown changes in the brain function through neuroimaging as the result of cognitive behavior therapy, or CBT, focused on identifying and correcting the errors of thinking underlying the experience of anxiety for an individual. In the case of obsessive-compulsive disorder, or OCD, the brain may be constantly sending message that something is wrong and requires immediate attention, leading to obsessional thoughts and repetitive compulsive behavior. OCD may also involve disturbances in other brain circuits that usually suppress repetitive behaviors, leading people to feel like they are stuck. Next, we'll take a look at the treatment options available to individuals diagnosed with anxiety or obsessive-compulsive disorders from the various perspectives. We will explore first the treatment options available from a psychodynamic perspective, followed by options from a biological perspective, a behavioral perspective, and finally a cognitive perspective. We will finish up by looking at some new options opening up through avenues of current research. The treatment option available to individuals from a psychodynamic perspective are designed to foster the client's awareness of their hidden inner sources of conflict. Traditional psychotherapy focuses on sources of stress from past relationships and experiences, where modern psychotherapy focuses more on current rather than past relationships and encourages the development of more adaptive behaviors. Shifting our focus to the biological perspective, we need to explore the functioning of the brain and identify anything that is out of the ordinary in order to try to bring it back into balance. Research demonstrates that anxiety results from an imbalance of neurotransmitters. Benzodiazepines are frequently used in the pharmaceutical treatment of anxiety disorders because they create a calming effect. However, it is important to note that prolonged use of benzodiazepines can result in a physical dependence, leading to withdrawal symptoms when medication is terminated. Typical withdrawal symptoms can include rebound anxiety, insomnia, and restlessness. From the biological perspective, research has demonstrated that antidepressant drugs can be beneficial in treating symptoms of anxiety as well. In the case of panic disorder, social phobia, and OCD, successful use of tricyclic and SSRI, or selective serotonin reuptake inhibitor, antidepressants has been demonstrated. Newer research shows that the use of SNRI, or serotonin and norepinephrine reuptake inhibitors, has been more effective for panic disorder. Looking specifically at OCD, symptoms have been shown to respond well to SSRIs by regulating serotonin neurotransmitter function. In an OCD patient with severe symptoms who has not responded to other treatments, neurosurgery is considered an option. A cingulotomy is a procedure in which the cingulate gyrus, which connects the limbic system to the frontal lobe, is severed. Some studies demonstrate positive results, but it is yet too early to determine safety and effectiveness. It is important to remember that drugs are not cures, but rather they are symptom control. Relapse is common after medication is discontinued. Research indicates that drug and CBT, or cognitive behavior therapy in combination, is more effective than either alone. This combination has become the gold standard for treating anxiety disorders. From a behavioral perspective, treatment is focused not on creating awareness of buried unconscious conflicts or on manipulating the functioning of the brain through pharmaceuticals and procedures, but rather it is focused on manipulating and changing behavior. Systematic desensitization is a fear reduction procedure aimed at gradually presenting progressively more disturbing stimuli, usually fictional representations, while the client remains calm and relaxed through a gradual process. Clients acquire relaxation skills and learn to remain calm in the face of the thing that is creating their anxiety. Gradual exposure is the process of exposing a client to the actual thing that is creating the anxiety in gradual steps. This is the example you saw in the video case of Marvin, where he had been gradually brought to the point where he could be with the dog and actually touch the dog. This took time and many small baby steps of becoming comfortable with the idea of a dog, pictures of a dog in a cage at the other side of the room, and so on, before he was able to actually come face to face with the dog in the park that day. After completing this video lecture, click on the link provided on Blackboard for a short explanation of graded exposure by a therapist in the field. In gradual exposure, it is important not to progress to the next step until the client is calm with the current step and ready to progress. The case of Chu, shown on this slide, is taken from page 130 of our textbook. Take a moment to see the steps involved to bring Chu from afraid of an elevator ride to able to take the elevator. Gradual exposure has been demonstrated to be an effective treatment approach for phobic disorders, including agoraphobia and social phobia. For individuals with social phobia, clients are instructed to enter increasingly more stressful social situations until the urge to escape has lessened. Exposure therapy is often combined with cognitive behavior therapy, or CBT, to help reshape cognitive faulty cognitions or thinking patterns for individuals with social anxiety disorder. For individuals with agoraphobia, graded exposure is also successfully used. The individual is accompanied by a trusted companion or the therapist during a graded exposure trial. Eventually, the person will be able to handle each situation alone and without discomfort or an urge to escape. Effects have been shown to be long-lasting, as we saw in the video, the case of Melissa, at the end of Lecture A. When treating an individual with obsessive-compulsive disorder, or OCD, response prevention is used. The client is purposely put in a position that will trigger the obsessive thoughts and then physically prevented from carrying out the obsessive behavior. For example, an individual with a cleanliness compulsion that needs to wash their hands excessively in response to an obsessive thought that their hands are always covered in germs. A therapist might have the client get their hands just a little bit dirty and then not allow them to wash their hands. The client slowly learns to tolerate the anxiety while being prevented from performing their compulsive rituals. Repeated exposure to the obsessional cues in the absence of adverse consequences will encourage the undesired behavior to stop. Going back to our example, the client will eventually realize that nothing bad happens if they don't wash their hands every time they feel the anxiety from the obsessive thoughts. Research demonstrates that the PET scans of OCD patients who have received CBT demonstrate actual change in brain function as well as behavior, the same change seen when patients are treated with the SSRI antidepressant Prozac. For individuals with panic disorder, CBT training is provided to teach skills relating to handling the panic sensation without catastrophizing. Cognitive refocusing is a strategy that forces concentration away from the experience of the panic sensations by forcing focus on a cognitive task, such as reciting the alphabet backwards or counting to 100 by sevens. Correcting faulty cognitions or thought patterns is the process of reinterpreting body sensations and understanding that they will subside naturally without consequence. By teaching a client breathing retraining, a normal level of carbon dioxide will be restored in the blood by having the clients breathe slowly and deeply. This will also avoid hyperventilation. Finally, from a behavioral perspective, engaging the client with panic disorder in any form of relaxation training will provide them with the tools to overcome a panic attack. From a cognitive perspective, the treatment focuses on helping the client to identify dysfunctional or distorted beliefs and replace them with rational or adaptive alternative thoughts and beliefs. Using the technique of cognitive restructuring, a cognitive behavioral therapist can help clients to recognize logical flaws in their thinking and help them view situations more rationally. Clients actively participate and gather information that will test their beliefs and show them that their beliefs are untrue. The case of Sreya from page 134 of your textbook demonstrates how an individual with a phobic fear of elevators can learn to overcome their fear through cognitive restructuring. To help overcome her fear of elevators, Sreya imagined herself getting stuck in an elevator, encountering the self-defeating thoughts she might be having with rational self-statements. She closed her eyes and reported the thoughts that would come to mind. The psychologist encouraged her to create a rational counterpoint to each of them. She then repeated the exercise in her imagination and practiced replacing the self-defeating thoughts with rational alternatives, as in the example shown on this slide. Take a few moments to see how self-defeating and anxiety-provoking thoughts can be changed to rational and empowering thoughts. Finally, let's take a look at a new treatment that has emerged from recent research. Virtual reality phobia therapy is a form of gradual exposure therapy that uses virtual reality to confront clients with the thing that they fear. In the illustration on this slide, the researcher is testing a virtual reality therapy system to treat a specific phobia of spiders, also commonly referred to as arachnophobia. The system contains eye-tracking software to study a person's response when exposed to virtual spiders in a virtual environment. When you have finished this video lecture, click on the video link referred to above from your Blackboard site posted immediately under this lecture. It's a quick 2-minute exposure to a virtual reality program that helps individuals overcome a fear of heights. As we conclude this last section on the perspectives and causes the perspective of causes and treatments for individuals with anxiety and obsessive-compulsive disorders, I am providing a table that illustrates the 4 perspectives in the far left column and connects them with the underlying causes and treatment options available for each. Take a few moments to look through the differences in both understanding and treatment from the various perspectives and consider how they can be used to complement one another, as we saw in the case of the combination of medications and CBT. This takes us to the end of Module 5 on anxiety and obsessive-compulsive related disorders. Please be sure to watch the video links provided on Blackboard to enhance your understanding of the ideas that we've been discussing in this module. Also, please be reminded that there is a link to your weekly assignment and quiz at the end of this module, and also on the assignments and tabs on the assignment and test tab on Blackboard. You have the week to work through the module, and your assignments and quiz are due on Friday, June the 12th before midnight. There will not be a lecture next week, but instead you will have the whole week available to write the midterm test. I will be sending an announcement with more information about the test later on in the week. I hope you enjoy the module. Have a great week, and bye for now.